Welcome back to the deep dive. Today, we are undertaking a really critical mission, especially if you are in any way involved in acute patient care or, are preparing to master the clinical world of medical surgical nursing.
Hmm.
We are diving into the systematic assessment of neurologic function.
And this is so much more than just anatomy. I mean, this is really the ultimate clinical shortcut. If you know the wiring diagram of the nervous system, how it's supposed to work, then a single finding at the bedside can instantly tell you exactly where a problem is,
Right, whether it's a stroke, a spinal injury.
or even metabolic failure.
Yeah.
So our goal today is to provide that step-by-step roadmap, moving from the microscopic neuron all the way up to the massive diagnostic scans. We're focusing entirely on that foundational knowledge and the assessment techniques you need as a nurse.
It's complex material for sure, and the language is everything. So before we map out the system, let's get those crucial clinical flags defined. You really have to speak this professional language instantly.
Let's start with movement control. You'll hear the term agnosia. This is the loss of the ability to recognize familiar objects through a specific sense.
So, they can't identify a key just by feeling it?
Exactly. That's tactile agnosia. Or they might see a cup, they know it's a thing, but they can't name it. That's visual agnosia. The sense works, but the brain's recognition center doesn't.
Okay. Then you have incoordination, which is ataxia.
Right. Ataxia is that inability to coordinate muscle movements. It shows up as a wide, unsteady gait, maybe difficulty with fine motor tasks, or even slurred speech. It's a classic cerebellar sign.
We also talk a lot about muscle tone. Let's talk about spasticity.
Spasticity is that sustained increase in muscle tension when you try to passively stretch a limb. It kind of fights you. It's a classic sign of, say, an upper motor neuron injury.
And the opposite of that would be flaccidity.
Totally. Complete lack of muscle tone. The limb just limp, floppy. It provides zero resistance.
And the two biggest flags for an acute change. I'm thinking delirium and the Babinski sign.
Absolutely. Delirium is that acute, confused state. It often starts with disorientation, and it is never, ever normal. It demands immediate intervention because if you don't treat the cause, it can lead to permanent damage.
It's an emergency.
It's a full-blown emergency. And the Babinski reflex, this is non-negotiable. If you stroke the sole of an adult's foot and their big toe fans up and the other toes fan out,
That's the pathological Babinski sign.
that's it. It indicates a failure in the motor control pathways coming down from the cerebral cortex. It is a massive red flag for CNS disease.
And finally, let's distinguish dizziness from vertigo. They're not the same thing.
Not at all. Dizziness is vague, a feeling of imbalance or being unsteady. Vertigo is very specific. It's the illusion of rotation, that feeling that you or the room is spinning, that almost always points to a vestibular problem.
Understanding just those 6 flags already gives you a huge head start in patient triage.
For sure. So now let's start building the model from the bottom up, the basic wiring of the body.
Okay, so the basic functional unit of this entire complex system is the neuron. It's structured to receive, process, and transmit information. You have the dendrites taking in messages,
Right, they're like the antennas.
the cell body handling the processing, and then the axon shooting those impulses away.
And that speed is key. That's why you have the myelinated sheath. Think of myelin as the insulation on a high-speed data cable.
Oh, that's a good analogy.
Yeah, it ensures that the electrical impulse travels as fast as possible. If that myelin breaks down, like in diseases such as multiple sclerosis, the signal is dramatically slowed or just lost entirely.
And the neurons, the stars of the show, they don't work alone. They're massively supported by glial cells.
Massively.
Right.
Glial cells outnumber neurons by a ratio of something like 50 to 1. They're the essential scaffolding. They protect, nourish, and clean up after the neurons. They do all the support work.
But electricity alone doesn't complete the circuit. Communication between the cells is chemical, and that's where neurotransmitters come in.
Exactly. These are the chemical messengers. They get released into the synapse, that tiny little gap, to make sure the message jumps from one neuron to the next or to a target cell like a muscle.
And the action of these messengers, it really dictates the function of entire systems. The source material has a vital table on this, and as a nurse, you have to know which ones are associated with major diseases.
You do. So acetylcholine, okay, say for example, that's the major transmitter for the parasympathetic nervous system. It's usually excitatory, heavily involved in muscle contraction.
And clinically, that's the one impaired in myasthenia gravis, right?
Precisely. Its action is blocked. and that leads to profound muscle weakness.
Then you have norepinephrine, which is kind of the opposite. It's the major player in the sympathetic nervous system, the fight or flight response.
Right. Usually excitatory. It profoundly affects mood and overall activity levels.
Then you have the modulators. Serotonin is inhibitory.
Yeah, it helps control mood, appetite, sleep, and it inhibits pain transmission.
And the most fascinating one, I think, in terms of movement is dopamine.
Oh, yeah. It's usually inhibitory, and it affects behavior, attention, emotions, and critically fine motor movement. This is your direct link to pathology.
A decrease in dopamine. That's Parkinson's disease.
That's the hallmark of Parkinson's. And don't forget the big inhibitory heavy hitter, GABA. That's the central brake in the whole system. And then, of course, the body's natural painkillers, enkephalin and endorphin. They're excitatory and inhibit pain transmission while giving that pleasurable sensation.
What's remarkable here is the diagnostic bridge this knowledge creates. I mean, we aren't just guessing about these levels anymore, are we?
Not at all. Advanced imaging like COPE and SPECT scans are now sophisticated enough to actually detect abnormal levels of dopamine and other transmitters. It provides that powerful link between the chemistry and the clinical diagnosis.
Which takes us straight to the command center.
Yeah.
The central nervous system, the brain.
Right. It only accounts for about 2% of your body weight, but it demands 15% of the entire cardiac output. It's a very hungry, dense organ. And an interesting side note, its weight does decline a little with age, from around 1,400 grams down to about 1,200.
And the main structure is divided into the cerebrum, the brainstem, and the cerebellum. The cerebrum is the largest part, made of two hemispheres connected by the corpus callosum.
Which is basically the information superhighway. It's transmitting memory, sensation, and learning discrimination between the right and left sides of the brain.
The outer surface, the cortex, is defined by all those folds, the gyri and the sulci.
The bumps and the grooves. And we have to know the four lobes because damage to any one of them produces a very predictable clinical syndrome.
Okay, let's break down that functional geography of the cerebral lobes, kind of using that clinical map, figure 62, as a guide.
So the frontal lobe is the largest and most complex. This is your executive suite. It houses concentration, abstract thought, memory, personality, and most importantly, motor function.
And it's also home to the Broca area, right? Usually on the left side.
Yes, which is responsible for the motor control of speech. Literally getting the words out. Damage here severely affects your judgment and your inhibitions.
Okay, then the parietal lobe, more centrally located, is sensory.
Purely sensory. It analyzes incoming sensory information, gives you your awareness of body position, that's proprioception, and allows you to discriminate the size and shape of objects without even looking. It's all about spatial awareness.
Moving down, we have the temporal lobe.
That's primarily auditory. It contains the receptive areas for sound, memory of sound, and the understanding of language and music.
Which is why a lesion there can cause receptive aphasia. They hear the words,
but they have no idea what they mean. They don't understand them.
And finally, the occipital lobe at the very back.
All vision, visual interpretation, and memory. If you bump the back of your head and see stars, that's your occipital lobe protesting.
Now, deep beneath the cortex, we have those vital, smaller centers, the subcortical structures.
Yeah, and they're hugely important.
The thalamus is often called the grand relay station.
It is. It processes all sensation except smell. It also plays a huge role in memory and filtering pain impulses before they go up to the cortex for final interpretation.
And right below that, the hypothalamus. If the brain had a utility closet.
This would be it. It's the master regulator for everything involuntary. Temperature, fluid balance, hunger, the sleep-wake cycle, blood pressure, emotional responses. And it controls the entire autonomic nervous system.
And the basal ganglia. These are the deep masses responsible for smoothing out and controlling fine motor movements.
Yeah, all those subtle adjustments we make in our hands and feet.
Below the cerebrum is the brainstem, the absolute non-negotiable survival center.
It connects the brain to the spinal cord. It includes the midbrain, the pons, and the medulla.
The midbrain contains important sensory and motor pathways, linking the cerebrum to the lower structures. Cranial nerves 3 and 4 originate there.
Then the pons, which is the bridge. It helps coordinate the two halves of the cerebellum and regulates respiration, working very closely with the medulla. Cranial nerves 5 through 8 emerge from the pons.
And the medulla oblongata. This is where your reflex centers are for respiration, heart rate, blood pressure, coughing, swallowing.
And most critically, this is the point where most of the motor and sensory fibers cross over a process called decussation.
Right, decussation. And that's why a lesion in the right side of the brain often causes symptoms on the left side of the body.
You have to internalize that cross-wiring concept. It's essential to localize an injury correctly at the bedside. The medulla also contains the beginning of the reticular formation, which controls arousal and the sleep-wake cycle.
And tucked under the occipital lobe is the cerebellum, the great coordinator.
It ensures that movement is smooth, accurate, and sustained. It's responsible for balance and position sense proprioception. If you have impairment here, you get ataxia.
Okay, so let's talk about the defense mechanism, the protection for this very sensitive organ.
First line is the rigid skull. And the key point here is rigidity. Since the skull cannot expand, any added volume, blood, fluid, a tumor forces tissue to be displaced.
Right, there's nowhere for it to go.
Nowhere. Inside the skull are the meninges, those 3 layers of fibrous tissue. The outermost is the dura mater, and it's tough.
And when pressure builds up inside the head, brain tissue can be forced against the folds of the dura or shifted downward.
Which is known as herniation. This is a catastrophic, often terminal event, and we also have to be mindful of those potential spaces, the epidural and subdural spaces, where bleeding can accumulate really fast and cause fatal compression.
The middle layer is the arachnoid, delicate and web-like. It holds the subarachnoid space where the cerebrospinal fluid, CSF, circulates.
And that CSF is produced in the choroid plexus of the 4 ventricles. It flows through a series of very narrow channels. If any of those channels get blocked, you get a pressure backup, causing obstructive hydrocephalus.
And CSF should be clear, colorless. It's produced at about 500 millils a day, though only about 150 millils is circulating at any one time.
Right. And critically, that CSF is absorbed back into the venous system through the arachnoid villi. If those villi get obstructed, say from blood after a hemorrhage or inflammation from meningitis, you get communicating hydrocephalus.
So production is normal, but absorption is blocked.
Exactly. And that distinction is vital for treatment.
Okay. Given how much the brain relies on constant oxygen and nutrients, its cerebral circulation must be pretty unique and fragile.
It is. It consumes 15% of your cardiac output, about 3/4 of a liter per minute. And the plumbing is unique. The arteries and veins aren't parallel like elsewhere in the body, and the arteries only have 2 layers, making them more prone to rupture under high pressure.
And the arterial supply is divided into the anterior, the internal carotids, and the posterior, which are the vertebral and basilar arteries.
And these 2 systems converge to form the circle of Willis.
The ultimate collateral circulation backup plan.
It is. If one major artery gets blocked, the circle might be able to reroute blood flow. But the forks in the road, the bifurcations along that circle, are common weak spots and frequent sites for aneurysm formation.
And the venous drainage is different. It doesn't follow the arteries.
No. Blood drains into the big dural sinuses and then into the internal jugular veins. And the key difference here is that cerebral veins have no valves. They rely solely on gravity and pressure gradients for flow.
This all leads to the blood-brain barrier.
Right. Formed by these really tight junctions in the capillary walls and support cells, this barrier restricts what chemicals and substances in the blood can actually get into the CNS tissue.
It's an incredible defense mechanism protecting the brain from toxins.
It is, but clinically it's a huge problem. It prevents many necessary medications like certain antibiotics or chemotherapy from reaching the CNS to treat infections or tumors. And that barrier could be compromised by trauma or low oxygen.
Okay, let's move down to the spinal cord and the vertebral column. The cord itself is an extension of the medulla, but it only goes down to the first lumbar vertebra, L1.
Right, below L2 you have the cauda equina, which is just a collection of nerve roots.
And in a cross-section, that H-shaped central gray matter holds the nerve cell bodies. The anterior horns are motor, posterior horns are sensory.
And surrounding that is the white matter, which is made of all the myelinated fiber bundles, the tracts.
Understanding the tracts is the key to localizing a lesion.
It's everything. We have 2 major sensory highways, the ascending tracts. One highway carries pain and temperature, and those fibers cross over immediately upon entering the spinal cord.
But the other one, the one that carries position, vibration, and fine touch.
Those fibers travel all the way up the spinal cord to the brainstem before they cross.
So that functional separation is your clinical shortcut. If a lesion is in the lower spinal cord, you can see these really specific patterns of sensory loss that help you pinpoint the exact level of the injury.
Absolutely. And the descending motor tracts, mostly the corticospinal tract, carry the impulses for voluntary movement, and they cross over high up in the medulla.
And the bony vertebral column protects the cord. 7 cervical, 12 thoracic, 5 lumbar. Nerve roots exit through the intervertebral foramen.
And any compression there, say from a herniated disc, is going to impact the peripheral nerves.
Which brings us to the peripheral nervous system, PNS, cranial nerves, spinal nerves, and the autonomic nervous system.
The cranial nerves are 12 pairs that emerge directly from the brain. We group them by function: sensory, motor, and mixed. Assessing these is a systematic way to check for dysfunction in the brainstem and cortex.
And the 31 pairs of spinal nerves have specialized roots. The dorsal roots are sensory and map to specific areas of skin called dermatomes.
And the ventral roots are motor.
Finally, the autonomic nervous system, ANS. This regulates all those involuntary functions controlled by the brainstem and hypothalamus.
It's all about maintaining homeostasis.
And we have the two great opposing forces. First, the sympathetic nervous system, SNS, the fight or flight response.
Right, predominantly excitatory using a norepinephrine. It's the adrenergic system.
Well, what does that look like? You get an increased heart rate, bronchial dilation, peripheral blood vessels constrict, so the skin gets cool, and your pupils dilate.
And you get that increased perspiration. And we have to pause here to mention a specific clinical syndrome, the sympathetic storm.
Often seen after a traumatic brain injury.
Yeah, due to hypothalamic overstimulation, you see these rapid, extreme swings in consciousness, vital signs, agitation, and just profuse sweating. It's a terrifying sign of severe brain dysregulation.
And the opposing force is the parasympathetic nervous system, PNS, rest and digest.
Right, active during non-stressful times. It uses the acetylcholine. It's the cholinergic system.
So its effects are generally restorative. Decreased heart rate, pupil constriction, increased salivation, and peristalsis.
The health of the patient really rests on that delicate balance between these two systems.
We've established the wiring. Now let's talk about what happens when the wires get cut or short-circuited. Understanding dysfunction depends so heavily on where the damage occurred.
For sure. Motor function begins in the frontal lobe and travels down the corticospinal tract. And all these vital fibers, they converge into this tiny little bundle called the internal capsule.
This is a critical insight. Think of the internal capsule as the most dangerous real estate in the brain.
It really is. All the motor fibers for the entire opposite side of the body are packed so tight right there.
So a lesion the size of a pinhead?
A tiny lesion in the internal capsule can result in a total hemiplegia. It's far more devastating than a much larger injury scattered across the cortex. That's your clinical shortcut for lesion localization.
Okay, this is a concept that trips up so many students. The essential breakdown between upper motor neurons, UMNs, and lower motor neurons, LMNs.
Yeah, it's fundamental. Think of it this way. The upper motor neuron is the command from the brain.
Right, it's the start the movement signal.
Exactly. Yeah. When that command is cut off, like in a stroke, the local reflex arc in the spinal cord is still intact. But now it has no supervision.
It just goes wild.
It goes wild. That's why you get spasticity, hyperactive reflexes, that classic Babinski sign. The muscle is still getting signals, just not the right ones.
And with a lower motor neuron lesion?
That's different. The final wire to the muscle itself is cut, so no signal at all.
And that means flaccid paralysis.
Total flaccid paralysis. No tone, no reflexes, and the muscle wastes away really fast. That's atrophy. Recognizing spasticity versus flaccidity is an immediate triage tool.
Movement isn't just about initiation, it's about coordination.
Right, and the cerebellum handles the fine-tuning, ensuring everything is smooth and accurate. Impairment causes that generalized incoordination or ataxia, plus loss of tone, weakness, and fatigue.
And the basal ganglia modulate this. Their major effect is to inhibit unwanted muscular activity.
Right, so dysfunction there doesn't cause true paralysis, but it causes significant motor interference. This translates into rigidity, posture problems, and involuntary movements.
And those involuntary movements are clinically distinct, aren't they?
Oh, very. You have coarse tremors, like the resting tremor in Parkinson's, athetosis, which is slow writhing motions, or those spasmodic, uncoordinated jerks. This tells you immediately the problem is in those deeper subcortical structures.
Okay, now let's consider the sensory system function. As nurses, we rely on the patient to report what they feel, but we need to know where that information is being processed.
Right, and you have to remember that critical difference in the crossing points. Pain and temperature fibers cross immediately in the spinal cord. Position and vibration travel all the way up the posterior columns before they cross in the brainstem.
This means the pattern of sensory losses dictates the lesion site.
Precisely. Total loss in a specific distribution. That suggests a peripheral nerve problem. But if a patient reports a loss of pain sensation but can still feel vibration, you know the lesion must be impacting the spinothalamic tract specifically. That points you right to the spinal cord.
And the thalamus is the integrating center.
Yeah, it gives you that conscious awareness of pain, temperature, touch, and the ability to recognize size and shape. So lesions in the thalamus or parietal lobe will impair all of those senses.
We have spent a lot of time on the wiring, but this next section, the nursing examination, this is the most critical for practice. I mean, you can't put your hands inside the skull, so the systematic physical exam is your only immediate window into everything we just discussed.
That's it. Now, that systematic process starts with the health history. You have to gather information while you're simultaneously observing the patient's overall appearance, posture, movement, and effect. Family input is often vital, especially if the patient's consciousness is altered.
When you're documenting symptoms, focus on the onset. Was it sudden or gradual? The character, severity, location, and critically, the progression and any relieving or exacerbating factors.
Common neurologic symptoms that demand detailed inquiry include pain, seizures, and remember, the type of seizure reflects the affected brain area. Dizziness or vertigo, visual disturbances like double vision or nystagmus, and muscle weakness.
And the family and social history is paramount. You have to ask about genetic conditions like Huntington's or ALS, age of onset and relatives, and don't forget trauma history and current alcohol or drug use.
For sure. So the physical assessment has 5 core components. And remember, your priority shifts based on the patient's condition. In an emergency, you're jumping straight to LOC and basic motor function.
The single most important component, the first thing you assess, is consciousness and cognition.
Because it is the most sensitive indicator of change in neurologic function, period.
Mental status begins with just observation, appearance, grooming, posture. We test orientation to person, place, and time. We assess immediate and remote memory.
For intellectual function, we test higher cognitive processes. Can they repeat a sequence of digits? Can they do serial 7 subtracting 7 from 100? Can they interpret proverbs? Failure on those tasks often points to frontal lobe damage.
We assess thought content and emotional status. Are thoughts relevant? Are there hallucinations? And is the patient's affect their external expression of mood appropriate to what they're saying?
Right? Is it flat or irritable or weirdly euphoric?
Language ability is a systematic assessment of understanding and communication. Aphasia is that deficiency in language function.
And we know where to look. Auditory receptive aphasia, Wernicke's, is temporal lobe damage. Expressive speaking aphasia, Broca's, is frontal lobe damage.
And finally, the level of consciousness, LOC. You observe their alertness and ability to follow commands. If they're unresponsive, you grade their response to a painful stimulus.
And that change in LOC is the earliest warning sign of increased intracranial pressure or a metabolic emergency. It's the first domino to fall.
Next, examining the cranial nerves. We are systematically comparing right and left functions. Let's hit the high-yield tests.
Okay, CN2 is olfactory, test smell. CN2 is optic, test vision. But crucially, CNs 3, 4, and 6 are tested together, checking pupils, eyelids, and eye movements in all 6 directions. Any deviation suggests a brainstem problem.
CN7, facial. Ask them to smile, raise eyebrows, puff out their cheeks. You're looking for symmetry.
CN9 and 10, glossopharyngeal and vagus. Check the gag reflex, watch the palate move when they say, ah, and note their ability to swallow and speak. Loss of that gag reflex means a high risk of aspiration.
CN11, accessory. Test shoulder shrug against resistance. CN12, hypoglossal. Ask them to stick out their tongue and move it side to side.
Done. Third component, examining the motor system.
You start by observing their gait and posture. Inspect the muscles for symmetry and any involuntary movements.
Muscle tone is tested by assessing resistance to passive movement. You're looking for those key abnormalities. Spasticity, rigidity, like the cogwheel rigidity in Parkinson's, or flaccidity.
For muscle strength assessment, we test their ability to flex and extend against resistance, always comparing left to right, and you can't skip the subtle tests.
No, the drift test is simple but so powerful. Have the patient hold their arms straight out, palms up, and close their eyes. If one arm slowly pronates and drifts down, that's a subtle sign of weakness you might have missed.
And we have to use the standardized 5-point scale for documentation. It's non-negotiable for consistent assessment.
Absolutely. 5 is full power. 4 is moderate resistance, slight weakness. 3 is the crucial one. They can overcome gravity, but not any added resistance.
2 means they can move the limb, but only if gravity is eliminated, like sliding it on the bed.
Right. And 1 is just a trace contraction you can feel. 0 is nothing. You have to document using this scale, ideally on a stick figure chart to show the pattern.
Next is balance and coordination, which assesses the cerebellum and basal ganglia.
For upper extremities, we check rapid alternating movements and point-to-point testing like finger to nose. For lower extremities, the heel-down tibia test.
And the key screening test for balance is the Romberg test.
Yeah, patient stands with feet together, arms at their side, eyes open. Then they close their eyes for 20 seconds. If they lose their balance once the eyes are closed, that's a positive Romberg. It indicates an abnormal reliance on visual input for balance, pointing right to cerebellar or vestibular dysfunction.
The fourth component is examining the sensory system. This is all subjective, relies on the patient's cooperation with their eyes closed. And you have to know your dermatomes.
You do. We test tactile sensation with a cotton wisp. We test superficial pain with a sharp versus dull differentiation of a broken tongue blade. And a crucial safety note: never use a safety pin.
Right, infection control.
Big time. We test vibration and proprioception. Vibration uses a tuning fork on bony prominences. Proprioception involves moving their big toe up or down and having them identify the direction.
And we also test higher cortical sensory ability, the brain's ability to interpret complex sensation.
Yeah, things like two-point discrimination, extinction, where they fail to notice a touch on one side when both sides are touched at the same time, and tactile agnosia, the inability to identify an object by touch.
The final component is examining the reflexes.
Deep tendon reflexes, DTRs, are tested with the reflex hammer. Make sure the limb is completely relaxed. If they're diminished, you can use isometric contraction, have the patient lock their hands, and pull to enhance the response.
And we use the grading scale. 2+ is normal, 0 is no response, 4+ is hyperactive with clonus.
That 4+ rating, or just the presence of clonus, that rhythmic, involuntary muscle contraction, is highly abnormal. Sustained clonus always signals CNS disease and needs immediate investigation.
Superficial reflexes are just graded as present or absent. The loss of the corneal or gag reflex signals a high risk for corneal damage or aspiration. Those are critical nursing priorities.
For sure. And finally, pathologic reflexes. These are the reemergence of infant reflexes, signaling CNS degeneration. The biggest one, again, is the Babinski sign. That abnormal toe fanning response in an adult is definitive proof of corticospinal tract disease.
When we transition our focus to the older adult population, there is one foundational nursing principle that must guide everything.
You must never attribute abnormality or dysfunction solely to aging without a proper, thorough investigation.
Localized weakness is always pathology, not normal aging.
Always. That said, some structural changes are expected. We see neuron loss, slower nerve conduction, decreased brain weight. Cerebral blood flow is reduced, and temperature regulation gets less efficient.
Motor alterations are common. We see reduced muscle bulk, decreased strength, and increased reaction time. The gait often becomes slowed and wide-based, which critically increases the fall risk.
Which is a top safety priority.
Yeah.
And DTRs might be reduced or even absent, especially the ankle jerk.
Sensory alterations are profound and have massive safety implications. Dull tactile sensation means a higher risk for unrecognized injury. Visual changes like sensitivity to glare mean nurses have to ensure adequate non-glare lighting and use nightlights.
Hearing loss contributes to confusion and isolation. A decreased sense of taste and smell is a major safety risk. They might not detect a gas leak or spoiled food.
And regarding pain and temperature, older adults often feel cold more readily. More critically, their reaction to painful stimuli may be significantly decreased.
So you have to use extreme caution with things like heating pads. They can suffer severe burns before they even report discomfort, and conversely, they may underreport severe pain, like from a heart attack, just because their perception is altered.
And mental status changes are the most frequently misinterpreted. While mental processing time slows down, core functions like language, long-term memory, and judgment should remain intact.
Any acute change is pathology, and the nurse has to strictly differentiate delirium, that acute confused state, from chronic irreversible dementia.
Delirium is a huge risk factor in older patients with infection or dehydration.
It is, and prompt recognition using screening tools like the Confusion Assessment Method, CM, is mandatory. Delirium is an emergency. You have to treat the underlying cause.
The nursing implications for the aging patient require adapting every single interaction.
Yes, you assess the consequences of their neurologic deficits on their ADLs, you implement aggressive fall prevention, you adapt your teaching, use a low-pitched, clear voice, adequate light, large print, and most importantly, an unhurried pace with short, concise material.
Okay, let's get into the diagnostic evaluation. The nurse's role here is defined by education, preparation, safety, and monitoring.
Right. For any procedure with contrast, you educate the patient on the purpose and side effects and assess women of childbearing age about contraception or breastfeeding.
Starting with imaging, computed tomography, CT scanning, uses a narrow X-ray beam for cross-sectional views. It's quick and highly sensitive for acute issues like hemorrhage, tumors, or infarction.
And your nursing interventions are key. The patient must lie still, which sometimes requires sedation and close monitoring. If contrast is used, you check for iodine or shellfish allergies and assess kidney function because the contrast is cleared renally.
Right. NPO for 4 hours prior and then push fluids after to flush the contrast.
Exactly. Magnetic resonance imaging, MRI, uses a powerful magnetic field. It's superior to CT for visualizing soft tissues and things like tumors, stroke, and MSX. It gives clearer images earlier.
And the nursing interventions for MRI are all about non-negotiable, high-priority safety.
Absolutely.
Yeah.
You have to rigorously screen for any ferromagnetic implants, aneurysm clips, certain orthopedic hardware, cardiac devices. A cochlear implant, for instance, will be permanently inactivated.
This is a massive safety alert for every nurse.
It is. You have to ensure the removal of all metal objects. Jewelry, watches, keys, credit cards. Metal-backed medication patches can cause severe burns, and most critically, no metal patient care equipment. Oxygen tanks, wheelchairs, fly-V poles can enter the MRI suite.
The magnetic pull is so strong, it turns them into flying projectiles.
It poses an immediate risk of severe injury or death.
The patient lies in a narrow tube with a loud thumping noise. We have to manage claustrophobia, often with sedation, or by using an open MRI if possible.
Positron Emission Tomography, PET, is different. It measures organ function, like metabolism and blood flow, not structure. Since the brain uses so much glucose, PET is great for detecting metabolic changes.
So we use it for things like early Alzheimer's, locating seizure foci, and distinguishing tumor tissue from dead tissue.
And nursing care is about explaining the possible sensations, dizziness or lightheadedness, and encouraging relaxation.
Single-Photon Emission Computed Tomography, SPEC, is a 3D perfusion study using radionuclides to capture cerebral blood flow. It's less expensive and good for detecting abnormally perfused areas like in a stroke before it shows up on CT.
Right. And nursing interventions are mainly about contraindications, pregnancy and breastfeeding, and monitoring for allergic reactions.
Cerebral angiography is invasive. It's an X-ray of the circulation after injecting contrast into an artery, usually the femoral or radial.
It's used to check vessel patency, collateral circulation, and for identifying and treating things like aneurysms.
So pre-procedure, the nurse checks BUN and creatinine, hydrates the patient, and marks all peripheral pulses for a baseline.
Post-procedure monitoring is high priority. You need immediate and continuous neuroassessment for signs of embolism or dissection. You have to observe the injection site for bleeding and continuously monitor the color, temperature, and pulses of that extremity.
Myelography is an X-ray of the spinal subarachnoid space after contrast injection via lumbar puncture.
It's used to outline the spinal cord to look for distortion from tumors or herniated discs. Post-procedure care is all about preventing complications. HOB elevated 30-45 degrees, bed rest, and, most importantly, encourage lots of fluids to prevent that post-LP headache.
Okay, then we have the non-invasive vascular studies like carotid flow studies and transcranial Doppler.
They use ultrasound and Doppler to evaluate blood flow velocity. They're non-invasive tools to detect stenosis, or with transcranial Doppler, severe vasospasm after a subarachnoid hemorrhage.
Electroencephalography, EEG, records the electrical activity of the brain via scalp electrodes. It's the gold standard for diagnosing seizures, organic brain syndrome, and confirming brain death.
Right, and they might use activation procedures like flashing lights to try and evoke abnormal discharges.
So for the nurse, this means the patient may need sleep deprivation the night before. And importantly, the nurse is responsible for withholding medications that alter brain waves, anticonvulsants, tranquilizers, stimulants for 24 to 48 hours.
Don't omit meals, though, as blood glucose changes can also alter the pattern. And assure the patient they won't get an electric shock.
There's a valuable research insight here. Continuous EEG monitoring in critically ill patients shows that even routine nursing care suctioning repositioning can cause abnormal stress responses.
Yeah, so nurses should consider shorter, less frequent interventions in these sensitive patients to minimize that neural stress.
Electromyography, EMG, uses needle electrodes to measure the electrical potential of muscles.
Useful for muscular disorders and neuropathies. You just need to teach the patient to expect a sensation like an IM injection and maybe some muscle ache afterward.
And evoked potential studies, EPs, measure nerve conduction time in response to stimuli.
The critical nursing intervention here is ensuring the patient remains perfectly still throughout the test to prevent movement artifacts from corrupting the signal.
Finally, the lumbar puncture, LP, and CSF examination. A needle is inserted into the lumbar subarachnoid space below L2.
The major risk, if an intracranial mass is present, is herniation. If you remove fluid from below a high-pressure system, the brain can shift down. So an LP is contraindicated if you suspect increased intracranial pressure.
The nurse's role is to assist with precise patient positioning relaxed. Fetal position is often best.
And CSF analysis.
Yeah.
The fluid should be clear and colorless. Pink or bloody fluid suggests a subarachnoid hemorrhage. And you have to send the specimens to the lab immediately.
And the dreaded post-LP headache.
It's common. A throbbing headache, much worse when sitting or standing, caused by CSF leakage. Management is all on the nursing role. Aggressive analgesics, lying supine, and crucial interventions like hydration and caffeine.
Since many of these procedures are outpatient, patient and family education is just paramount.
For sure. They need clear, concise instructions on post-procedure care, especially monitoring for complications like bleeding or severe headaches, and when to call for help.
And transitional care ensures safe follow-up. For older patients or those with deficits, we have to make sure appropriate transportation and monitoring are available.
Right. Reinforce follow-up appointments and make sure the family understands the significance of any new neurologic deficits so they can manage care safely at home.
What an immense journey. From the anatomy of a myelinated axon to the intricacies of the Babinski sign, and through all the complex safety protocols of an MRI, we've really covered the entire systematic approach needed to assess and care for a patient with neurologic concerns.
And if we connect this entire framework back to the essential bedside nursing priority, it all circles back to that very first sign of trouble.
The most sensitive indicator of the system's function is the level of consciousness.
Every time.
So here's a final provocative thought for you to consider. Given how common seemingly benign factors like a simple infection like a UTI or dehydration or a minor drug interaction can cause acute delirium, which is a massive change in LOC, how does the nurse's daily assessment of orientation and mental status redefine their primary role? If that change in LOC is the earliest warning sign of a catastrophic failure, the nurse isn't just a caregiver. They are the primary sensor and the first line of defense against potentially devastating, irreversible neurologic damage.
Internalize that assessment priority. Thanks for joining us for this deep dive.